Hello, everyone. I am Dr. Bensley Gonsalves. I am a consultant diabetologist at Bliss Diabetes Center in Vasai. So today we'll discuss about a case, a newly diagnosed type 2 diabetic case and early initiation of a combination. We'll talk about it in the future podcast. So to begin with, Mr. A is a 45-year-old male with newly diagnosed diabetic, type 2 diabetic who visited our clinic 6 months back with multiple risk factors like obesity, hypertension, hyperlipidemia. He was initiated with metformin and advised for change in his lifestyle and diet modification. Recently, he visited again as part of his routine checkup. His laboratory workup showed following reports. His HbA1c was 8.5%, eGFR was 80 ml per minute per 1.73 meter square, LDL 80 mg per DL, HDL 38 milligrams per DL, triglycerides 200 milligrams per DL. He is on the following medicines at present: metformin 1000 milligrams twice in a day, lisinopril 40 mg once a day, metoprolol extended release 100 mg once a day, atorvastatin 40 mg at night, aspirin 75 milligrams in a day. His physical examination reveals that he is obese with a BMI of 31 kg per meter square. BP is 120 by 70. Heart rate is 78 beats per minute and regular. His other systemic examination doesn't show any abnormalities. So, what does the evidence indicate? The evidence indicates that early intervention and achievement of glycemic control reduces the long-term risk of microvascular and macrovascular complications in type 2 diabetes. That is according to UKPDS. This UKPDS demonstrated a legacy effect of early intensive therapy because the difference in the CV event rate 10 years post-trial was apparent even though no difference in HbA1c levels between the intensive and conventional therapy was seen. When metformin is not suitable, and empagliflozin or linagliptin is being considered as an alternative first-line treatment, initial combination therapy may be considered to achieve a target more quickly, particularly in patients with high baseline HbA1c levels. So, early combination therapy in type 2 diabetes makes clinical sense for several reasons. Firstly, a meta analysis demonstrated that early use of combination therapy significantly increases the likelihood of achieving the glycemic target of HbA1c of less than 7% compared with metformin monotherapy alone. So for patients with HbA1c of more than 1.5% above goal and diagnosis, the ADA and ESD guidelines recommend that the first line treatment with a dual combination and an SGLT2 inhibitor as the first drug post metformin treatment in patients with established CVD, CHF, or CKD. EMPA and LINA combination with a complementary mechanism and pleiotropic benefits may be the suitable option across a range of patients, especially our patient, including those with established ASCVD or high risk established heart failure or CKD due to the tolerability of the combination. In addition to potential benefits of empagliflozin on the CV and renal outcomes, and no increased risk of heart failure with either of the agents. According to study, early achievement of HbA1c goal of the 7% with EMPA-LINA could reach target HbA1c at 12 weeks compared to monotherapies. So HbA1c reduction by EMPA-LINA combination of 25 milligram and 5 milligram has demonstrated 1.81% HbA1c reduction at baseline HbA1c of more than 8.5% at 24 weeks in metformin treated groups. The benefits on glycemic control were maintained even after week 52 in metformin treated groups, and a higher percentage of patients achieved HbA1c of less than 7% were reported for combination group. The combination offers a suitable component in strategy to achieve target HbA1c without increased risk of hypoglycemia and weight gain, with improvement in overall lipid profile, a reduction in the incidence of genital infections across associated with SGLT2 has been reported when a DPP4 inhibitor is added. This is perhaps because of better glucose control, although other possible mechanisms remains to be investigated. So to summarize, EMPA-LINA combination provides a robust HbA1c reduction and a 2 to 4 times higher odds of patients reaching the goal HbA1c of less than 7% compared to individual agents with low risk of hypoglycemia. So this will be the ideal drug to start in this patient, which we had seen 6 months back and who was newly detected type 2 diabetic and who had not reached his HbA1c target even after 6 months of metformin monotherapy. Thank you.